Viera, Duke Majan with Duke Spine Institute, and we are getting ready to perform our final surgery of the day. This is a Duke laser disc repair, L45, L5S1. Our patient has pain. It is left side.
Left approach, yes, sir. Louis, is that good?
Is that my signature?
That was Jason.
So you'd have to either come back and get you, or ask Jason to sign.
Oh, I thought I already saw him.
You saw him, we did our timeout.
And I didn't.
Sign.
Oh, weird.
And I forgot to remind you, your glasses look weird.
My glasses are what?
Looks like that lens is,
Is it pushed out?
it looks like it's pushed out. Okay, it's okay.
It may just be that way. I got Coke bottles. I've got some thick lenses. Okay, sir? We're getting ready to get started. It's your left leg that bothers you? All right, not your right side, correct? All right, this is Dr. Duke Majan. I'm sorry for the long wait today. I know you waited all day. You're very tired and hungry. So you're going to get to go to sleep soon, okay? Now, before I put you to sleep, I need your help getting to where I need to go. So I'm going to be touching your back, just feeling around a little bit. Just make sure I get to the right place, okay? All right. Then I'm going to do an injection of some medicine so you'll feel a little stick and burn. Okay? Little stick and burn. Don't be alarmed, that's normal, okay? Just try to lay still and take it easy. If you feel pain, just say ouch. If you say ouch, then I know that you're uncomfortable and I'll give you some more medicine, okay? All right. Deal? And we're doing 4551, correct?
Correct, sir.
All right. All right. Remember, if you're uncomfortable, say ouch, but don't move your body around. You comfortable right now where you are? All right. We're going to get started then. You're doing great. Everything's okay. You'll hear some noises. You'll hear us talking. All that's normal. Okay? Shut. You just let me know if you're uncomfortable. Lateral. Monica?
Sir?
You better not do too good of a job.
Ben,
Yes.
Ben,
No fear, I'm a little rusty.
make sure there's no exposure, please.
Alrighty, whenever you're ready. Yeah, a little better shot than that. There we go. That's more like it. Alright, so we're going to need to drop. Are you fluoros all the way to the ground?
I'm to the ground, sir.
You're all the way to the ground.
Yes.
Then we need to bring the table up just a quarter inch. I move north, just a little bit north. And we may have to wag a slight amount, but your iliac crests look pretty well lined up. Uh-huh. All right. That's pretty good. What do you think?
I like it.
I like it too. I like it too. All right. I like it. So just go ahead and lock it in. Sir, are you comfortable? Shot. 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 Let's get an AP. Not too bad. Let's go back to a lateral view. Shot. That's it right there. Shot. Yeah, I need to be north just a little bit. Shot. Alright, it's pretty good. Getting close. Shot. You okay? Where do you feel that? Alright. I apologize. Shot. Alright. Shot. Anything? You feel anything? Alright. Alright. Well, you're doing really, really good, my friend. Everything's going well from us, okay? We just got into the 5-1, which is the hardest to get. So that's very encouraging. Okay. Okay, good. All right. I need that Raytech back. We're going to go ahead and we've already accessed 5-1. We're going to access 4-5 next. Shot. A little low. Shot. Blood pressure's good. See if we can bring it down just a little bit. Shot. Shot. You doing all right? Everything's good here, so just relax. Shot. Shot. All right, so we're almost at done at 4-5. Another really nice root, but I can feel the herniation right here in the foramen. I can feel it. So it doesn't look that bad on MRI, but you can see it. There's a big tear. Went in very easily. Go ahead. All right. So now we've accessed both discs. How much is your problem is back versus leg? Mostly leg.
Back is constant.
You get back pain all the time?
Yeah.
Okay. Where do you feel that?
Back.
In your back?
Yeah.
That's you, Monica. And how bad is that on a scale of 1 to 10? 10 being the worst pain of your life. How bad did it get up to?
Like a 5 or 6.
That's it? You're about to, I mean, you don't have to be stoic. Just really, what number would you give it?
Probably like an 8.
8? Is that your typical pain that you get every day?
No.
I mean, you get that pain in that location every day.
Oh, yeah.
But it's not that bad.
Nowhere near.
It's just in that location.
Yeah.
Got it. So it's typical, and it's 8/10.
Ah.
How bad is that on a scale of 1 to 10?
That was like a 10.
10. Come on, that's you, Monica. When I look up, that's you. Woo! That's a huge tear. That's a grade 5 tear. All right, sir. The good news is when you wake up, we'll be done.
Okay.
So you get to go to sleep now.
All right.
Count from 1 to 100
Okay.
by ones out loud.
1, 2, 3, 4,
Shot.
5, 6,
You're doing good.
8,
Now in French.
9, 1, 2, 3, 4,
Nice.
5,
Six.
6, 7, 9,
Wheat.
8, 9,
All right, you're doing good. Let's see that shot. So the guide wire came back just a little bit.
13, 14,
Shot.
15, 16, 17, 18,
Shot.
19, 20, 21.
You might feel a little burning in your arm. That's just the medicine going in. Okay? That's going to put you to sleep. You're doing really good. Keep going. All right. He's going to sleep. You're doing good. You're doing good. Just keep counting. So, Sean, we're going to do L5S1 first. L5S1 is a massive, massive disc herniation. And I'm hoping we can get all of it out with this approach. I actually am approaching it a little more lateral so I can get over to the midline of the disc, because this is a huge herniation. Shot. Are you awake? Getting to the foramen. Shot. All right, so we're going to enter the foramen now. Neuroforamen. When I say foramen, I'm talking about the neuroforamen. That's the hole where the nerves come out. And that's the problem, is this patient has a ginormous tear. How's he doing? You know what? I think we're off a little bit. Okay? I think you need to bring my side, maybe my side up or your side up. One or the other. I can't really tell from the way he's laying. Are you level? Because it doesn't look like it on the sacrum.
I'm on 90.
Shot. I'll tell you if you got better. That's a little better, I think. Well, let's try a little more. Let's see what happens. Maybe the wrong way. I think it's the other way. You see the back of the sacrum where it's not lined up? Hit it. Is that it?
That's it.
Try going a little more. Shot. What do you think? It looks like it's getting worse, huh?
Makes you like it better where it was to begin with.
Alright, go back to where it was. He may have some rotational component. Is that where it was?
Yes.
Alright, well, we'll be happy with that. I am up against the herniation in the foramen. I just went past. Shot.
Let me know.
Shot. I'm going to take the guide wire out. Shot. Is that it? Oh, there. Alright. Yeah, just lay still. Everything's okay. He's moving around a little bit. I'm going to be stimulating a little bit more and then we'll be on cruise control. Just lay still. Everything's okay. Shot. How's he doing? Are we okay? Should I wait or proceed? Yeah, that's fine. Take your time. So folks, at this point, we made a small incision, 7 millimeters on the side, and I'm going to be bringing this tubular retractor. It's basically a metal straw that goes down along the dilator and enters into the disc herniation right where the disc herniation is happening. And this creates a portal, a way for me to operate on the disc and bring my instruments down from the operating room into the disc herniation directly. We do this without removing any bone or ligaments from the spine. Shot. It's one of the advantages of this particular technique is the fact we don't have to remove the bone of the spine. Instead, we go through a natural hole that's already there. Shot. All right, let's go to get the fluoro out. Let's go, fluoro out. Keep it sterile, is what he's saying. Because we're going to need it again in a few minutes. Let's go, let's go, let's go. Just a little further out. That way Luis and I aren't banging against it. Just slide it out. Yep, perfect. That's probably good.
Lights off.
All right.
Let's go on, please. Go on. Stand by light, you see?
All right, we are inside the disc. Grab her. He's moving a little bit. I don't know if you're okay with that. I'm okay with it. But what? So we're going to start taking the herniation out. Strap on the arm. Lay still. Everything's okay. Luis.
Yes, sir.
There's another piece of herniation. He's got a pretty big herniation, so I'm going to go ahead and just start lasering because we're going to have hopefully we're going to find a big piece that we can get out soon. We're inside the disc herniation. Anything going on with the left here? What is that? Shoulder?
Yes.
Standby laser. Let's turn the light down just the slightest amount, please. Oh yeah, see that? There's a huge herniation there. Trying to tease it out. Can't even. Oh well. It's going to be coming out in pieces. It's nice when you get the whole thing and you can pull it out, but I'm not ready for that yet. Here's another big piece. Yeah, see how it just gave way? Big piece, yeah.
There. Please.
So the reason I'm not using the laser as much is I'm trying to grab a hold because this patient has a very big herniated disc fragment, and I'm trying to grab a hold of it and see if I can just fish it out. And I'm just getting big pieces, but I'm not able to fish the whole thing, and that's fine. In the end, we want to get the job done. It's just nicer if we don't have to go in and out so many times. All right. Let's bring the laser back in. Any questions, Sean, from our audience?
We do have one.
All right, I'll take it in a second. So just for those of you who don't know, I'm Dr. Ara Duke-Majan, CEO and founder of the Duke Spine Institute here in Melbourne, Florida. We're based out of Florida, and we perform all types of spinal procedures, surgical and non-surgical. And what you're watching today is surgery. Typically, our surgeries are done on Tuesdays, sometimes Thursdays. Today we had a long day with 4 surgeries. This is the last surgery we're doing for today. This patient has a herniated disc at L5S1 as well as one at L45. The one at L5S1, the one we're working on currently, is by far the largest one. The Duke laser disc repair is an endoscopic surgery. It's state-of-the-art surgery. It's not done open, it's done with a small incision, and it's done with a full endoscopic, which means down a little tube with an endoscope. If this patient had open surgery, it would be a lot more invasive and more extensive and more risky. A lot more collateral damage. But by making a tiny little incision, I can get inside the disc and I can repair it, as you're seeing, using a laser. Now, there is going to be a big piece of herniation somewhere in here, and I'm trying to find that herniation. We want to get it out. Okay? I'll take the question.
We have someone wondering, do
Stand
you
by.
recommend home health care after a spinal fusion that is done outpatient? If so, is it always necessary?
All right, so the question is, do I recommend home health care after someone has a spinal fusion? And is it always necessary? The answer is yes. It is necessary. It depends on what kind of spinal fusion the patient has. But for certain types, like lumbar fusions, posterior cervical fusions, I think home health care is essential. For anterior cervical fusions, it may not be necessary. So I would say it depends on the type of fusion we're talking about. It also depends on the patient and the kind of support they have from their family. Do they have a nurse at home, part of their family? Do they have friends and family members that can provide them the kind of care they may need after a surgery like that? For the most part, the most important thing is transfers, basically from bed to chair, bed to bathroom, and medication management, and then making sure the patient stays hydrated, drinks a lot of fluids, etc. All right, laser. What you're seeing, folks, the blue line is the laser fiber, we call it. And the laser fiber is being used to remove some of the soft disc herniation and really to free up the herniation. The herniation itself is large, and standby laser. And what happens over time is the herniation will stick to the surrounding tissues, okay? And it gets really hard to get it out, so you have to use the laser to free it up, to get it off of the annulus. Okay. Yeah, the herniation will get scarred to the annulus fibrosus because the herniation itself is the nucleus pulposus, and it's extremely pro-inflammatory. The next disc, which is the 4-5, is not quite as bad. It's definitely herniated, but it's smaller. And it is causing his pain as well, but really, I think most of his symptoms are coming from the L5S1. So our main focus is L5S1, making sure that we get as much of that herniation out and get the annular tear repaired.
We have another question.
Sure.
Someone's wondering, do you recommend fusion over disc replacement?
Oh, that's a great question. Do I recommend fusion over disc replacement? So, I'm going to tell you the answer is qualified yes. Okay? But it depends on who's doing the fusion. The very best disc replacement results are not as good as the very best fusion results. Okay? So I have a little bit of time, I'll talk to you about it. When artificial discs first got approved in the United States, I was there basically involved with some of the trials at the University of Florida. And we were putting in artificial discs at the time, and a few of our hospitals that we collaborated with over in Tampa, like University of South Florida, they were putting in artificial discs, and doctors were just starting to put them in. And what I saw was that the patient's results with artificial discs were not very good compared to fusion. They didn't get rid of as much pain with the artificial disc as we could with a fusion, if it's done properly. That doesn't mean that you should all go out and just get a fusion by somebody because it's going to be a better result. What it means is you have to really understand, there's two questions, there's two issues. Number one, is fusion better than artificial disc? In my opinion, if you have the very best fusion compared to the best artificial disc surgeon, the very best fusion surgeon will get a better result for the patient. Second question, which is, is my surgeon, who I'm going to have the surgery with, are they better at artificial disc or are they better at fusion with respect to their results? That's really the most important question, because it doesn't matter if I'm really good at fusion if I'm not doing your fusion surgery, right? So if I have a success rate of 95% elimination of your pain, but I'm not doing your surgery, and you're having your surgery with Dr. Green, and Dr. Green's best results are 50% relief of pain with fusion, but he can do 80% relief of pain with artificial disc, then maybe you should be having an artificial disc if you're going to have Dr. Green do your surgery. So I think you really have to talk to your surgeon and understand what they do best, and then they'll tell you what the right surgery is for you. If you say, you know what, I don't care where I have to go, I want the very best, then the best surgery is going to be what you're watching right now, the Duke laser disc repair. It's better than fusion and better than artificial disc. But you're going to have to travel to get it. I don't know if that answered the question, but it's really a complicated answer. It depends on who's doing the surgery. All right. Big tear. You can see the end plate there. Maybe a little light. Huh? No, I'm talking to the anesthesiologist. So you can start to see a lot of this collagen up here. There's the herniation right there. You see it, folks? It's starting to come out like a sausage or a piece of pasta. Stand by. That's another part of it. I need I need him asleep for a little bit longer, obviously. Just one little piece, unfortunately. So the problem with this herniation is that it's broken up into a lot of pieces. So we're going to just have to take them all out. A little bit at a time. Did they have a follow-up question?
No, they did not.
Okay. Look at that granulation tissue right there, the pink stuff. See it right there? Stand by. Let's go back with the laser. He's coming up a little bit. Why so much epidural fat? Well, nerves require a lot of energy to work. So the fat's there to provide them an energy source. You can store a lot more energy as fat. Tell me when I can proceed. Than you can as sugar. So you typically will find fat in parts of the body where, unless you're talking about the belly or the breast, which is obviously not the case, but you find fat typically localized, concentrated around areas where it's needed. Let me know when I can proceed. What?
I'll let you know.
Okay. You're still not happy.
We have a question.
Sure.
We have a viewer who says, I'm a new time viewer and I just found out that I have arachnoiditis and I'm in need of help. What should I do?
So one of our viewers has just been diagnosed with arachnoiditis and they want to know what to do. Well, the first thing you should do is confirm that you indeed have it. I would get a second opinion. The only ways to really get arachnoiditis are if the doctor has stuck a needle in your spine in your lower back and injected a very powerful dye into your spine, and that dye has now caused the nerve roots to clump together. The other way you can get it is if you had a pain management procedure and the surgeon or doctor doing the pain management procedure put a needle into into your thecal sac or where the nerves are accidentally, basically, is what it comes down to. So there aren't a lot of things that cause arachnoiditis. There's always an event that occurs that you know, oh yeah, that's when it happened. So if that is the case for you and there was some kind of a dye injected, then it's entirely possible you do have arachnoiditis. On the other hand, if that never happened to you, then it's entirely possible that you don't have arachnoiditis. So I think a second opinion is in an order for anyone that has arachnoiditis. He's really uncomfortable.
It might hurt for a second.
Huh?
I just needed to hold up my hand, the IV's in my eye.
Okay, we'll just wait. So let's say you really do have arachnoiditis. Then the treatment is going to be a spinal cord stimulator. That's what you're going to need. How are we doing? That's fine. We definitely need it. Just lay still. Everything's okay. You guys get the IV going?
Keep it going. This is bouncing between stress pain and
You can almost see individual red blood cells. That's the vein. Tiny, tiny little vein. Look at the blood coming out of it. A little waterfall cascading. Huh? Okay. Yeah, he's still not happy about that. Want me to wait? Huh? Just wait or don't wait? So this herniation is pretty scarred in here.
yeah, after. Yeah, I do it after.
Stand by. a nice chunk of herniation. I think that's going to help. Yeah, let me see the laser. Stand by. Okay, laser. This is the herniation, by the way, in case you're all wondering. We're inside of it. We're debriding it, debulking it. It's pretty massive. But we've got about, I don't know how much, but maybe 50% of it so far. We're inside the actual herniation. That's what you're seeing. And I'm basically just removing it from the inside out. And it's so very scarred in. So How's he doing? Stand by. Oh yeah. Nice.